And I have my, so you guys see my screen up there, atypical cases?
Yes.
Okay. All right, so I'm going to start it. And this is, it's a little bit maybe a little bit more advanced, not a simple case, but we'll see how we can go. So basically, we're going to, those are the objectives for the session. Whoops, what did I do? There we go. There's the objectives for the session. So why is my thing not working? There we go. Okay. So patient number one was a 29-year-old female referred for outpatient physical therapy clinic with diagnosis of left radial neuropathy. Her chief complaint was that she was unable to extend her left wrist. She had pain in the forearm and numbness and coldness in the hand. The symptoms started about 3 weeks prior to her coming into the clinic, but she couldn't really think of a cause. There was no like accident or no fall that she had. It just started about 3 weeks ago, and she couldn't recall any kind of trauma. Her history was not significant. She had family history of diabetes, but no other metabolic conditions or neuromuscular conditions. She was right-handed, which was the opposite hand of where her symptoms were, and she was a paraprofessional computer worker, but she was not working at the time. So here are her clinical exam findings. So here are her summary of her clinical exam findings, and we can see that she had some deficits. Her diagnosis, again, remember, was radial nerve injury, and she did have deficits in radial nerve innervated muscles distal to the elbow. She had elbow flexor strength slightly weak from the brachioradialis. Supination was weak, and wrist extension was also significantly weak. She had sensory changes over the radial distribution of the sensory nerve, with some point tenderness in the supinator and brachioradialis, and she had trouble doing basically any task with her left hand. But taking a look at the physical exam findings, there was something that kind of popped up when I was looking over the chart of the therapist who did the assessment, and I noticed there were other findings as well that didn't quite make sense with the diagnosis of radial nerve injury. She had weakness of the pronators, which are not innervated by the radial nerve, and of the wrist flexors, which also not innervated by the radial nerve. And she had significantly decreased grip strength, and the forearm flexors, as I mentioned, are not radial nerve innervated. So my colleagues called me up and says, you know, we have this patient. We don't know we get the diagnosis from the doctor, but we're not quite sure what's going on with the clinical presentation. So they called me up and they said, you know, can you come take a look and see what you think? So she was referred for an EMG. The doctor that referred her for physical therapy agreed with the plan of care, and I performed the EMG about 2 weeks after the initial PT eval. So she was getting some basic treatment, you know, basic strengthening exercises and some pain relief modalities and neuromuscular rehab and things like that. But I saw her about 2 weeks after the PT eval. Initially, I did a little bit more thorough exam. She had no other pain, no history of immunization or virus. She did report that she moved into a new apartment that was upstairs right before her onset of symptoms. So it wasn't a gross trauma, but it was a significant event. She used canvas bags, which are the reusable shopping bags, to carry up loose items, and she did make multiple trips. I also did a little bit more thorough. Instead of just a gross grasp assessment, I did muscle strength testing of the flexor digitorum longus and flexor digitorum profundus, and there was significant weakness of those two muscles. So based on those two muscles, any kind of idea of what you think may be going on with this patient? I think I muted everybody, so I don't know if anybody can hear me. Oops. hold on a second. Sorry. So obviously for the working hypothesis, we have to definitely consider radial neuropathy proximal to the posterior interosseous nerve and superficial radial nerve split, and an anterior interosseous nerve or proximal median neuropathy, because so she may have two kind of presentations going on. So the plan was to do a electrophysiologic plan was to do a median motor and sensory, radial motor and sensory, the anterior interosseous nerve, which is a little bit more advanced study, but it is a little bit, once you get the hang of it, it's not that hard to perform. An ulnar just to kind of surround abnormality with normality, and an EMG of extensive radial nerve muscles, but also the muscles of the anterior interosseous nerve. So the lateral heads of the flexor digitorum profundus, the flexor pollicis longus, and some other proximal muscles as well. So here's looking at her her median, whoops, sorry about that. Let's go back. So here's looking at her median her NCV findings, and we can see that the radial nerve had a significant drop in amplitude. There was a significant drop in amplitude from the elbow to the spiral groove. She had, and accompanied by a slow velocity. The right side was normal, left ulnar was normal. The left median to the APB had normal velocity and normal amplitude, but the anterior interosseous, recording off the pronator quadratus, we had normal latency, but again, a significant drop in amplitude. We had a significant drop comparison in amplitude compared with the left and the right. So we had a significant drop in amplitude. Sensory nerves all checked out normal amplitude, normal latencies. So the summary of the nerve conduction studies, there was left radial motor had slow velocity between the spiral groove and the elbow with significant amplitude drop. Normal radial motor and sensory amplitude distally, and left anterior interosseous amplitude was significantly reduced compared to the opposite limb. So the radial motor indicates that we have a myelin injury and with partial conduction block. It's not an axonal from what the nerve conduction tells us, because the amplitude of the distal stimulation was normal. So far we have no evidence of an axonal injury. It's purely myelin at this point. The radial motor and sensory distal amplitude, so we can assume that the axons were intact. And with the left anterior interosseous, we're not sure if the damage is from a conduction block or if it has true axonal involvement. We only have one stimulation site, so at this point we can't tell if there are damage to the axons or if this is just a conduction block. So there's the EMG data, and we can see the EMG that we had no spontaneous potentials and normal motor units, but the recruitment and interference was significantly reduced and abnormal in the muscles innervated by the radial nerve distal to the elbow, distal to the triceps, and also abnormal findings of the anterior interosseous, with the flexor digitorum profundus being abnormal, and flexor pollicis longus as well. So the final take-home from the electrophysiologic data was that there was no evidence of muscle denervation. So even though this was a relatively new onset of injury, about 5 or 6 weeks after the onset of complaints, she had no denervation potentials, no spontaneous potentials, so there was no evidence of axon damage, which is a better prognosis. However, there was significant conduction block, and conduction block, again, is evident because we had that very slow velocity and that reduced amplitude proximal to the injury site. So she had a slow velocity. She had a reduced amplitude proximal to the injury site, and she had significantly reduced recruitment and interference on needle EMG. So she's right at the cusp of, if she doesn't get intervention quickly, it may start to develop into axonal damage. So she needs the urgent intervention in order to start the recovery process. And here's a picture. This is not of the patient, but this is simulating her injury. And we can see here, this is the type of bag that she used and how she was using it. And we can see here that the proximal strap is right over the part of the radial nerve proximal to the split of the superficial radial sensory and the posterior interosseous nerve. And the distal strap of the bag is right over the anterior interosseous nerve, so right over the emergence of the anterior interosseous nerve. So by looking at the mechanism of injury, it correlates quite well with her symptoms. So how was EMG and nerve conductions helpful in this case? Well, the PT interventions after the test results came in, after I completed the test, is that she started receiving more intense interventions to the volar forearm. So we needed to address the anterior interosseous nerve injury as well. And she started doing some exercises in addition to radial nerve strengthening of the extensors. She started working on some of the forearm flexors as well. Because the urgency of the conduction block, her treatment plan was changed from 2 times a week to 3 times a week. And she did make a lifestyle modification. She stopped being friendly to the environment and using those canvas bags and started using good old-fashioned paper and plastic bags. Because those, if you try to hold those over your forearm, those will snap like a twig. So she did stop doing the aggravating activity. The overall patient outcome, she started once the intervention was properly applied, she started getting some strength gains about 1 week after the revised treatment plan. And I didn't see her, but I spoke with my colleagues who did. She had negligible deficits in her ADLs present in addition 3 weeks after the injury. And again, she stopped being friendly to the environment, and she's from New York City. So we have a tax on our groceries. So if we use paper or plastic bags, so she happily paid that tax to avoid another recurrence of the injury. So this was an interesting case because posterior interosseous injuries are, they commonplace, and anterior interosseous nerve injuries can be common, but not usually together. So this could have been something that was brand new, or did I discover something that somebody had already encountered? So in order to figure that out, I went to the literature. So common causes of mononeuropathy in the elbow and forearm are viral infection. That's why I mentioned the virus history in the history. Repetitive forearm flexion and extension or supination pronation can damage the radial and anterior interosseous nerve in the forearm. Repetitive elbow flexion, anatomical variance or compressions from adjacent structures, and recreational activity. Those have all been documented instances in the literature of injuries to the nerves in the forearm. Some external causes of anterior interosseous neuropathy or posterior interosseous nerve neuropathy of or the radial branch. Fractures are common. Obviously, they're going to damage the nerve at the location. And also slings. Slings after surgery have been shown. One very old study, one newer study, shown that slings after surgery can compress on the anterior interosseous nerve. Tennis elbow braces have been shown to damage the radial nerve if they're applied too tightly. In the military, prolonged holding of the weapon, of the M60 weapon, and also post-op dressing has been shown to injure the radial nerve and anterior interosseous nerve in the forearm location. However, there was not many reported cases of the two nerves being injured together. The posterior interosseous nerve was injured after intense and prolonged muscle contraction, and the patient, patient developed secondary posterior anterior interosseous nerve symptoms. When they did the surgery for that patient, they found constriction of both the posterior interosseous nerve, but was negative for anterior interosseous nerve. They found that some of the fibers of the going to the flexor pollicis longus are communicating between the anterior interosseous and posterior interosseous nerve, and this was just one isolated case. Another case showed that there were fascicular constrictions noticed during surgical inspection of an automechanic. Lab tests were positive for inflammation, so the theory for this patient was there was primary inflammatory disorder. So that was the first case, and we'll have questions at the end, and we'll go on to case number 2. And case number 2 was a 37-year-old female with low back pain radiating to the left lateral thigh and lower leg with numbness and tingling on the dorsum of the foot. The onset of symptoms were 8 weeks after carrying a heavy backpack during vacationing in the mountains. She also reports numbness and tingling of the right index, middle, and ring fingers over the last 6 months. Her occupation was a bank teller. She was right-hand dominant. She had no significant medical history, no family history, and no surgical history. So her physical exam, cranial nerve screen was normal. She had decreased sensation to the light touch in the bilateral median and fibular or perineal nerve distributions. Her strength was normal, except for the right APB. So she had some weakness of the right APB. She had absent Achilles reflex, but all other reflexes were normal, and she had no bowel and bladder dysfunction. For her electrodiagnostic plan, because of the APB weakness, I was thinking carpal tunnel syndrome. So I was going to do a test for carpal tunnel syndrome. So I was going to do bilateral, median, motor, and sensory nerve, and muscles relevant to a screen for carpal tunnel syndrome. But she also had low back pain. So I wanted to screen for a radiculopathy. So I was going to do the bilateral fibular motor and sensory and tibial motor as needed, the H reflex, and then a standard radiculopathy screen, 5 muscles, at least 5 muscles, including the paraspinals. And lastly, in the back of my mind, I was maybe thinking a peripheral polyneuropathy. Not likely, but just keep it in the back of my mind. So I was going to do a unilateral sural and radial sensory. So here's some of the data that I encountered, and it started to fit the pattern of bilateral carpal tunnel syndrome. So we had median motor slowing on the left at the wrist, and the right median motor had even more profound slowing at the wrist and a reduced amplitude. So we had slowing and reduced amplitude, so possibly a conduction block. We need to do our needle EMG to determine if that is true axonal damage or if this is conduction block that could be happening at the wrist. So she had even more pronounced slowing at the right than versus the left. The ulnar studies were okay. They were on the borderline of abnormal latent velocities, but still above the normal range. The sensory nerves were a little bit going along with the upper extremity motor nerves, in that the sensory right median was no response. So the motor studies were worse for the median nerve, and same thing with sensories. There was no response. And the left showed now we have possible, we definitely have slowing confirmed at the wrist, but now we have signs of possible axon damage as well. So we have possible axonal involvement with the reduced amplitude. The radial sensory and ulnar sensories checked out pretty normal. Lower extremities, started to cloud the picture a little bit. So I was thinking originally with lower extremity that it could be a possible radiculopathy, but looking at the lower extremity, we encountered slowing at the bilateral fibular neck. So in the bilateral fibular neck, again, not very profound, but still outside the normal range, there was slowing in the across the popliteal bilateral fib head segment bilaterally. The tibial motor had markedly reduced amplitudes. So we had reduced amplitudes of the bilateral tibial motor. So that, again, that could be this time with no evidence of slowing. So there could be some possible axonal involvement here as well of the lower extremity motor nerves. The lower extremity sensory nerves, the perineals were quite reduced. We had a decreased amplitude bilaterally of the superficial perineal sensory nerves, but the sural nerves were checking out to be normal. So we had normal latencies, normal velocities, and normal amplitudes of the sural nerve. H-reflex was not obtainable in either limb. So that's, again, we were doing H-reflex to rule out radiculopathy or to evaluate for radiculopathy, and we found there was no response on either H-reflex. So the summary of the nerve conductor studies were quite significant. We had a couple of unobtainable responses. We had reduced amplitudes of multiple nerves. We had prolonged distal latency of the median motor and left sensory. And we had slow velocity of the median nerve in the forearm, very prolonged, very borderline, and also the borderline slow velocity of the fibular motor nerve across the knee. The EMG summary, the data table was too big, so I just put a summary up here. Many of the muscles were normal, but she had increased insertional activity in the gastroc, and she had markedly positive spontaneous potentials in muscles innervated by the perineal or fibular nerve distal to the knee. So she had marked findings distal to the knee, and she had some chronic findings in the right APB. She had some complex repetitive discharges, which are seen in chronic neuropathy, and she had an abnormal motor unit potentials in the right APB as well, polyphasics as well as increased amplitude. So the impression, this is how I worded it. We had multiple findings in multiple locations. So this was a polyneuropathy, which is the definition of a polyneuropathy. She had multiple findings in multiple locations in no kind of pattern according to a single nerve, peripheral nerve, or nerve root level. So there was a polyneuropathy in the distal, bilateral, upper, and lower extremities. There was acute axonal involvement with evidence of some myelin involvement. The neuropathy demonstrates chronic and severe findings of denervation in both the distal median and tibial nerves. The demyelination is worse in common areas of entrapment of the median at the wrist and fibular at the knee. I referred the patient back to her primary care provider for evaluation, including appropriate laboratory studies. Now, remember, her medical history was normal, but she was out hiking in the mountains and in the wooded areas. And in the mountains of the New York, New Jersey area, we have a high presence of deer ticks, which could lead to Lyme's disease. And Lyme's disease can often cause a polyneuropathy because it does affect the nerves. So I didn't see any ticks when I was doing the test, but it is very common in the area to encounter people with history of Lyme disease and have findings of neuropathy along those findings. So clinical significance, unfortunately I didn't get the information on this patient after she was sent back to her own primary care provider. I did the test for a spine surgeon who was referring for her radiculopathy. She presented with the signs and symptoms of radiculopathy and carpal tunnel syndrome, but we found findings that didn't go along with that. The electrodiagnostic findings were consistent with a type of polyneuropathy called mononeuritis multiplex, and I'll talk more about that in a second. The electrodiagnostic findings were not consistent with other types of common polyneuropathies, such as alcoholic, diabetic, or hereditary polyneuropathies, which are by far more common. So what is mononeuritis multiplex? So mononeuritis multiplex is a not common polyneuropathy, but when it does happen, it has a very distinct presentation. It has painful, asymmetrical, and asynchronous sensory and motor peripheral neuropathy involving isolated damage to at least 2 separate nerve areas. So it's going to be more, the findings are going to be more pronounced at areas where nerves tend to be more susceptible to injury. As the condition worsens, then it starts to become more like the classical stocking glove polyneuropathy findings that would affect all the nerves distally and proximally, but first starts out just affecting a random pattern here and there. The pathophysiology for mononeuritis multiplex is that a lack of oxygen to the axon or myelin associated with a decreased blood flow or inflammation of blood vessels to the peripheral nerves. So again, the nerves need the supply of blood as well. So if they're not getting the blood supply, they will start to display and show damage, just as if they're being compressed by an external force. Common causes of mononeuritis multiplex are infectious is one of the common causes. And again, Lyme's disease correlates with this patient's clinical history and subjective history. So Lyme's disease was one of the things that I was thinking of. Again, obviously, with the electrodiagnostic study, we can't confirm that as a potential cause. That's why we referred her back to her primary care for blood work. But that is one of the common infectious causes of mononeuritis multiplex. There are other causes, such as rheumatological disorders and chronic conditions like diabetes, amyloidosis, and neurosarcoidosis can cause mononeuritis multiplex. But the most common cause of all forms of mononeuritis multiplex is unknown. So they're not exactly sure what causes it and why somebody would be predisposed to developing this. The differential diagnosis for mononeuritis multiplex is we need to look at and distinguish it from alcoholic neuropathy. And alcoholic neuropathy is a type of polyneuropathy where the axons will be decreased, will be damaged at the more distal locations. Brachial neuritis would just affect the upper extremities. Diabetic neuropathy will involve, again, similar to alcoholic, will involve the distal, but there will be findings of myelin damage as well in a diabetic neuropathy. Guillain-Barré syndrome will see more profound slowing with very little axonal involvement and very little amplitude and abnormal EMG findings. And Charcot-Marie-Tooth disorder, hereditary sensory motor neuropathy type 1 and 2, that's usually differentiated because that's an inherited disorder. So this patient had no history of any the disorders in the family. Clinical symptoms commonly seen with mononeuritis multiplex are low back pain that is unilateral and radiating to the knee, numbness, tingling, and paresthesias, or kind of general with mononeuritis multiplex. The physical exam will mimic sensation findings of entrapment neuropathy of the involved nerve. So the physical exam, if you remember, she had decreased reflexes and she had decreased potentials, strength of the APB. But most of all the other muscles were normal. The strength was only decreased in the APB. There also are signs of autonomic dysfunction. So that's why I mentioned in the case bowel and bladder dysfunction, and why it's important to ask for that when you're screening for your patients with suspected polyneuropathy, is to ask about bowel and bladder function. Laboratory studies are important for assisting with the diagnosis of mononeuritis multiplex, so standard CBC with differential, fasting blood glucose to assess for concomitant diabetes, the Lyme antibody titer, which should have been performed with this patient. Unfortunately, as I mentioned, I didn't get the follow-up. HIV blood tests, hepatitis screens, and ESR rate as well are indicated in mononeuritis multiplex. The electrodiagnostic criteria for differentiating mononeuritis multiplex is typically these patients will have a decreased amplitude of the sensory nerves and decreased amplitudes of the motor nerves. The velocities may be slightly reduced, around 70% below the lower limit of normal. Remember, the velocities of the perineal segments, they were abnormal, but right below the abnormal threshold. Late responses are typically absent or prolonged in most polyneuropathies, and also with mononeuritis multiplex. EMG we see usually for patients with mononeuritis multiplex that they have both acute findings of spontaneous potentials, and they have chronic findings as well. So we have acute findings of spontaneous potentials, fibs and positive sharp waves, and we have chronic findings as well, where we'll see abnormal motor unit amplitude, duration, and phases will be abnormal, with phases being increased. And it also follows a neuropathic type of pattern where we'll see a rapid firing rate and reduced recruitment. Treatment for mononeuritis multiplex, as far as PT goes, there's not much that we can do to address the neuropathy. We can try to reduce the pain with our pain relieving modalities or manual treatment techniques. We can use exercises as appropriate. We don't want to overtax the system, make the person as functional as possible. So, using your exercise prescription tools wisely and not overdoing these patients. Bracing and splinting if needed to help support, like carpal tunnel syndrome, can help relieve some pressure and relieve some external pressure off the nerve. But the bigger intervention is going to be the medical management. So analgesics and the dreaded O word, even though in general they try to avoid opioids, but for a short-term basis, the opioids have shown to be effective at reducing that breakthrough pain that is often accompanied by it. Corticosteroids, immunosuppressants, anticonvulsants, and cholinergic agonists are also often prescribed for patients with mononeuritis multiplex. So those were some of the references from what I found about mononeuritis multiplex and the anterior interosseous. So there's a lot of journal review for these two cases, and you're not going to do this all the time, but it can be something to look at in cases where you get atypical findings. You definitely want to refer back to the literature and see if this is something that is newly encountered, or if this is something that is has been described, but you just may be seeing this for the first time. So let's see if I can unmute people, and I think I'll try to do this here. And let's see. Everybody still here? Is anybody Anybody say anything?
Yep.
Yes.
Okay. Does anybody? This was again. These cases were a little bit complex, but I just kind of wanted to go through the thought process of what these two cases go through. So does anybody have any questions on any one of the thought process or the cases and the conditions in general? Any questions that you guys want to go over?
How often do you get a case like this with mononeuritis multiplex?
This is not one of the more common presentations. Mononeuritis multiplex is rare in general. By far, the most common I encounter for polyneuropathies are, diabetic neuropathies, alcoholic neuropathies, or drug-induced is another common cause, corticosteroids, Lyme's disease in the New York City area. Even though we're in a city, we do get, especially in Staten Island, where I work a little bit, we do have a high incidence of Lyme disease, so we do see that. So, but mononeuritis multiplex is one of the oddball ones, to use an incorrect term, but it's not something that will be encountered regularly. So it's not very common. But when it does happen, you'll take a look at your results, and it doesn't really make sense. The data that was for that patient, a typical patient with diabetic neuropathy, all the amplitudes would be reduced, or there'd be slowing in multiple nerves. But she had kind of spotty or patchy slowing in the certain areas. So the findings weren't consistent with the typical pattern. So that's why I wanted to present this case. It's not a common one, but it's one to kind of take a step back and say, well, what else is going on with this patient? So that's so again, to answer your question, it's not very common, but when you do see it, you'll take a step back and go, what's going on here? And that's where you need to maybe go back and look at either the textbook or literature and things like that.
Yeah, I think I would have been stuck on looking for symmetry myself and been totally confused if I had this case myself.
Yeah, and it's so that, and I had to, I did this test. Forgot how long ago it was that I did this patient. I tested this patient, but it's not the typical presentation. It's not the typical symmetrical presentation. It was kind of spotty, patchy here and there, but there is evidence of this type of condition, and just has to, sometimes when you see something out of the box or out of the ordinary, you're probably not the first person to see it. So if just doing a little, refer back to the literature or the textbook or whatever, and you can find that there are incidences of it. And again, it's not something you would comment on in the report. That's why my impression didn't mention mononeuritis multiplex. But looking at the pattern afterwards, it does fit along. She did fit along with that pattern of mononeuritis multiplex.
So even for you, it was an afterwards consideration later on?
I'm sorry, what was the first part?
So even for you, you had to look at it later on to really come to that conclusion?
Yeah, yes. Again, it's not something I see every day. Like I said, the most common ones that I see are the diabetic, the people with diabetes, the drug-induced or the hereditary, things like that. So even once in a while, I'll see something out of that I haven't seen in a while or haven't seen. So you document what you find, and then you go back and there will be evidence of it in literature sources. So it's something that I'll see things once in a while that I'll take a step back and say what's going on, and take a look back and to clarify for recommendations. That's why I referred this patient after I wrote the report. I did contact them. I said this person needs to get to their primary care because they need more extensive workup than their orthopedic surgeon or the spine surgeon who referred her for the testing. Anybody else have any other comments or questions or anything in general about either one of the cases or anything that they encountered that doesn't quite make sense, that just sticks out in the top of your memory or top of your head? That
Can we review your pick for the montage, the setup? You know, your clinical thinking in the montage, the nerves you chose to test? Because I would have, tested a lot more nerves just because I just would have. I
which case?
know what was going on.
For the polyneuropathy case?
Yeah,
Okay, yeah, let's go back
for
to
the
slide.
mononeuritis.
Yeah, okay, so let's go. Can you see the screen as I'm going through?
I sure can.
Okay. All right. So my initial plan was, again, looking at my initial plan was based on my initial differential diagnosis. So I was thinking in the beginning of carpal tunnel and radiculopathy. So those were the initial ones that I had started with. Screening for a carpal tunnel study, and then the radiculopathy. In the back of my mind, I thought maybe polyneuropathy, but I started out with the initial plan. But then once I started finding encountering the findings that I did, I added more. So I added the ulnar, motor, and sensory, and then I added the tibial and the superficial peroneals, and I started adding more to my initial plan as I went on. So my initial plan was, smaller, but then I needed to expand upon that as I was encountering the findings that I did. So my plan evolved to starting with just a textbook carpal tunnel workup or radiculopathy workup, and then expanding upon that based on the findings I was encountering.
Okay.
Hi, John.
Yes.
Yeah, I'm just wondering, like for EMG for bilateral CTS, why did you pick biceps?
Because I was going to screen for a C6. C6, the C6 dermatome overlays with the median dermatome over the wrist, and the index and the thumb. So I wanted to just do a quick assessment of C6 along with the flexor carpi radialis for C6 and C7, and also another median nerve muscle. So that's the reason why I was going to just suspect a quick C6 screen, and then based on see what was happening after that.
Mm-hmm. Okay.
Anybody have any other questions or comments or anything they want to talk about?
John, can we go over the impression of the second case?
Sure. So there's the impression. So she had a polyneuropathy and the distal bilateral upper and lower extremities. She had acute axonal involvement with some evidence of myelin involvement. So there was more. There was positive acute findings, but also positive chronic findings as well. So depending on the location, the chronic findings were localized to just the median and tibial nerve muscles, while the demyelination was present in mainly the common areas of entrapment of the median and fibular nerves. So it was kind of not diffuse demyelinating like you may see in diabetes or Guillain-Barré or things like that, but it was kind of spotty demyelinating. The demyelination was mainly focused at areas of the common sites of compression. So that's where I commented on the differentiate between just staying overall demyelinating to just demyelinating at certain locations. Where a typical polyneuropathy would have demyelination, diffuse and symmetrical, whereas this person's demyelination was localized to specific areas. So that's where I wanted to differentiate that as far as stating just myelin involvement, but I wanted to classify it as not being diffuse and particularly localized to particular areas.
Could you go back to your charts for the nerves you tested, the NCS, please?
For this case, right?
Yeah, for this case.
Okay. So there's the upper extremities, and we can see here that there was borderline slowing in the forearm segment, just one tick below the normal, but the slowing was localized for the upper extremity at the median, at the wrist. That's where the slowing for the motor nerve conduction slowing was. The ulnar latencies was normal, and the ulnar velocity, one of them was right at normal, but still normal, and the across the elbow segment was also normal, so there was no slowing across that segment. The sensories, for the upper extremity sensories, now usually in polyneuropathies, in kind of textbook polyneuropathies, the sensories are involved first and more pronounced and diffusely. But in this case, the radial sensory was normal. The ulnar sensories were both normal and pretty standard looking, and the findings in the sensory nerve were localized to just the median nerve and the upper extremities, while the in more common polyneuropathy presentation, you would see slowing, or we'd see either slowing, or we'd see axonal changes in sensory nerves more pronounced than motor. But that wasn't the case in this patient. That's why I wanted to highlight that in the impression.
Why did you choose to do D2 on the right and D3 on the right, and then just D3 on the left?
Usually I like to do D3 first. I find it just easier for me to do D3. So I had done D3 on the right first and got nothing. So I wanted to see if there was any potential that I would get it at the on the index finger, and it was the same thing. I got no response on the index finger on the right. Once I got the finding on the left on D3, which is what I usually start with, then I didn't need to confirm that. I had definite evidence of both slowing and amplitude changes on the left with because I got a response. Basically, the reason why I did D3 and D2 on the right is because I got nothing on the right, and I wanted to test further to see if I could get a response at a different location. But then once I got the response on the left, then I didn't do the D2 on the left as well.
Thank you.
No problem. And then the sensory, again, the sensory, usually the findings in polyneuropathy are the other way around, where the perineals are usually, the amplitudes are usually involved before the tibial, because the perineal EDB is much smaller than the abductor hallucis is. So we usually see pretty pronounced atrophy of the EDB in patients with like diabetic polyneuropathy. We'd see pronounced EDB morphology and amplitude changes, but again, that wasn't the case in this patient. In this patient, the amplitude findings were worse in the abductor hallucis. The slowing was present at the across the knee segment between the bilateral between the fib head and popliteal. but the amplitude findings were more pronounced in the tibial, which is usually opposite of the normal polyneuropathy pattern. And then to go along with the sensories, again, sural was totally normal. And again, sural is often involved first in polyneuropathies, and in this case, the sural was totally normal, while the superficial perineal sensory was abnormal. So we saw that there was some findings, and again, that correlated a little bit with the worsening of the perineal, with the with the possible axon damage, and which was evident with EMG as well. But usually in polyneuropathy and your standard polyneuropathies, again, the sensories responses would be much worse than the motor. And in this case, at least the sural was textbook normal, as far as what she was presenting with, from sensory findings. Any other questions or any other comments from the case? And these were complex cases. Again, these weren't ones you'd normally see every day, but these were sometimes things you will see. So just be aware that, occasionally, you'll see things that are not commonly encountered, and just those may be the times that you do need to, go back and check the textbook or check the literature, and talk about something that you haven't seen in a while, or haven't seen recently, or haven't seen at all, and use that to help you describe it. All right, so if there's no other questions, then I guess we'll call it a night. And those of you that are attending over the weekend, I'll see you on Friday, Saturday, and Sunday. And those of you that are not, if you have any questions, you can always email me. We can talk about the case further, and I hope to talk to you and see you all soon. All right, have a good night.